Hello, everybody. We're going to introduce ourselves along the way, but Julie has said that this is the first time she's ever done this, so please be kind to her. Okay. I know that Phil said something about our condition, so the bits that you are going to learn a lot about ciliopathies today, and I think we're probably going to go over a bit of ground that Phil's probably said, so excuse us for that. So we're going to talk about the current clinical experience with children with ciliopathies. And we're going to explain the different conditions, the number of patients, a little bit background about our charities that we run, what happens in our multidisciplinary clinics, how the clinics were funded, and then Claire on the end is a clinician for actually PCD, is going to tell us about why it's so important that children get access to these clinics. So I'm Fiona Copeland. I run the Primary Ciliary Dyskinesia Family Support Group, and the reason I run that is that I've got two children with the condition, aged 15 and 17, and I'm pleased to say they're both doing very well. So, and I'm more than happy to talk about them as well. My favourite subject, if you want to talk to me. I'm very good at talking about my kids. So Phil's explained that PCD is a rare genetic disease. It's recessively inherited. So I didn't know that I had this dodgy gene, and neither did my husband. So again, I can relate to Faith's experience of being hit in the gut with a genetic condition and how it makes you feel. So PCD is a defect of the ciliary ultrastructure. And it's the impaired mucociliary transport, so it stops the lungs from moving the mucus out of the lungs. And there's lots of different types of PCD, and I'm the spectrum of the disease. So some children have hardly any problems at all. They might have a little bit of hearing loss and the occasional piece of lung disease, but then other children have all of the symptoms possible. So my children particularly have problems with their lungs and not much problems with anything else, but I've met some children with all sorts of things. So the clinical symptoms are rhinitis, which is a runny nose, neonatal respiratory distress, so they're born with a cough or not very well, end up in skaboo, chronic wet cough, problems with their middle, fluid in their ear, hearing loss, sinusitis, and then Phil was describing situs abnormalities. You can have your heart and lungs on the wrong side. And so I've got some graphical pictures of what normal cilia look like, moving the mucus along, and this is what looks like if you've got PCD. The mucus just gets stuck, and so what you have to do is do physiotherapy to get that mucus out of the lungs. And I don't have PCD, but I do have a chest infection. So PCD affects 1 in 15,000, but there's a higher incidence of the PCD in the Asian population. We think this is due to consanguineous marriages. If you don't know what that means, it means when you marry your first cousin. But we think there should be about 3,000 people in the UK with PCD, but we've only got 300 that are in contact with our group. So there's quite a lot of people that are either undiagnosed or they're not in contact with the support groups. But the impact of PCD is that you have to have physiotherapy twice a day. There's a picture here of one of our members being beaten at our family conference. And we like to call it beating. We're allowed to beat our children. And you have to have targeted antibiotics, either orally or intravenously when they're poorly. And if you don't get diagnosed at an early age, you can have lung damage, permanent lung damage. And lots of children have hearing problems. And then later on to life, they get fertility problems. And on a day-to-day basis, it's how do you manage with a long-term condition? How do you make your teenage boy, when he's got things like GCSEs to worry about, how are you going to make him do his physiotherapy every day? And, it's bad enough trying to get them to clean their teeth when they're teenagers, but when you've got to make them do physiotherapy, it's quite hard work. So all of our patients have access to an annual review in a multidisciplinary clinic. And so they get to see a PCD respiratory physician, someone like Claire. They also get to see a clinical nurse specialist who they get to get a great relationship with that person. That's their first port of call if they've got a problem. And we literally have the telephone numbers and the email numbers and the text numbers of our clinical nurse specialists. And we also have access to a PCD physiotherapist, someone who really knows the condition, who can work out what's the best treatment for them, and also for ENT consultations. And our clinics, they're organised by the NHS, by the administrators of those systems. And I think the other groups are going to explain how their clinics are run. Our funding is that we have funding through the NSCAG, the National Commissioning Group, which I think has now disbanded and is called something else this week. But basically, we get our money from the NHS, and the NHS run our clinics. But the PCD Family Support Group do have a big access to those groups, and we're involved in how they're run and the auditing of them and regular meetings to make sure they are running properly. And we've been quite instrumental in making sure that they do have the funding to do that. So the charity itself is very small. We were formed in 1992 by a parent, and we're run by volunteers. And we have a committee of 8 people who all have an interest in PCD. They're either patients or parents. And I've been doing the job for 7 years and desperately trying to find someone else to do it. So I'm now going to pass on to Julie, who is going to talk about LMBBS.
Hi, everybody. I'm Julie Sales, and this is Tonya Heimers here, and we both work together on the clinics in London and Birmingham for LMBBS. The Lawrence Moonbardet Beadle Society was formed in 1987 by Michael and Drina Parker, who are here with us today at their kitchen table, who have a son with LMBBS, and we're presently managed by a committee of 8 trustees. Our main objectives as a charity are to preserve and protect the health and promote the welfare of those affected by LMBBS and their families, and to advance the education of the medical and educational professions and the general public on the subject of LMBBS. What is LMBBS? LMBBS is a rare recessively inherited ciliopathy, which includes visual impairment leading to blindness, obesity, extra fingers and toes, development delay, speech and language difficulties. We have emotional immaturity and learning difficulties, varying from just very mild right through to the Ostrom spectrum. Autism. Kidney abnormalities, and many other health conditions can occur as well. How many are affected? In the UK, approximately 1 in every 100,000 babies are born with LMBBS, and we estimate about 100 people are affected. We presently have 425 patients in our clinics, 160 children and 265 adults, as you can see, across Great Ormond Street, Birmingham, Guy's and Queen Elizabeth in Birmingham hospitals. The impact of LMBBS, well, from a bad impact, it's a complex syndrome. Delayed diagnosis is common. The lack of local knowledge leaves patients and parents feeling alone and isolated. We see this very often in the clinics. Poor medical, social and educational support, and poor health outcomes and limited life opportunities if not diagnosed early enough. But with early intervention, vital to improve long-term health outcomes, social and emotional support can minimise isolation, reduce the risk of depression and improve a family's long-term well-being. Again, we see that with the clinics if we get to the patients and the families early enough. Using an example of one of our patients, the family were given a potential diagnosis of BBS, however, that they were refused genetic testing based on cost, told to go back if his eyes failed. Child received early diagnosis of autism, however, no further medical checks or tests were scheduled. Mum asked for paediatric referral, however, the paediatrician was not interested in suspected BBS diagnosis and booked a yearly follow-up. At age 9, tests showed visual deterioration. However, paediatric appointment led to further frustration as consultant had little knowledge of BBS. The mum said the process was very traumatising and yet again left me feeling increasingly isolated and alone to care for my son. The multidisciplinary clinics. We held our first clinic at Great Ormond Street in April 2010. And there are 5 of us within the clinics. We have Great Ormond Street in London, we have Birmingham Children's Hospital, Guy's Hospital in London, and the Queen Elizabeth Hospital in Birmingham, and the LMBBS Society. The LMBBS ensures service remains patient-focused at all times. The funding comes through the NCG from 2010, and we have a 5-year contract signed. The LMBBS set up and manage the contract and the budget. We have 2 family support workers, which is Tonya and myself, and an admin support, which is Chris, and a finance officer, which is my husband, Kevin, and we're all employed to manage the service. And we have a good team of volunteers that also come and help us at the clinics if we need extra help. BBS family support workers. Tonya runs the children's service and I run the adult service. And our roles are as clinic list facilitation and patient liaison and advocacy. Pre and post clinic support and information. We try our best to be in contact with the patients very much before, during and after the clinic so that we can give them as much more support as they require, and then that makes that easier for when they come to the clinic if they've had that contact. And we assist with them with travel and accommodation if needed, and we support them on the day. We have just begun doing an extra form for benefit and social support, so we're trying our hardest to find out if there's any extra help or support that they may need along those lines, which is proving to be very successful. And we're post-clinic point of contact. We have quite a few patients that if there's a problem, we always say to them, please come back to us, and we will then put you forward to the clinicians and chase them up if need be. And again, that has worked out very successful because they feel like they're being supported all of the time and not just gone to an appointment and then left in the lurch. And we have a provision of newsletters and leaflets and our web page throughout the year. At the multidisciplinary clinics at the moment, the appointments run between sort of 15 to 18 months, and they have an access to a geneticist, a dietitian, an ophthalmologist, a nephrologist, and endocrinologist, a clinical psychologist, speech and language, which is only with the children's department hospitals at the moment, and a transitional care coordinator, which we have at Birmingham Children's Hospital, and our clinic nurse specialists at each hospital. And us as support workers, we're there with them throughout the day. The patient service. In the children's service at the moment, we run 8 clinics per year and 6 to 7 patients per session. When we began the clinics, it was only 5 clinics per year in the children's, so that has increased incredibly. The adult service, we have 6 to 8 clinics per year and 9 to 11 patients per session. And the growth across the service, in 2010 we had 200 patients, and we are now at the moment up to 435. The patient experience of a specialist clinic, and this is previous to the example that I gave you earlier of the bad experience that this family had. Sorry, excuse me. So following an appointment with the paediatrician, the mum contacted the LMBBS Society. The information leaflets and contact numbers were sent to the family. We paid for her family to attend the family conference, so the contacts could be made and support links were forged. It was obviously the first time she'd been to our conference, and she was very nervous and very emotional, but we were able to support her through the whole weekend. The support worker liaised with the hospital for the earliest possible clinic date, and on behalf of the family, bringing the appointment forward from September to July. And the mum now feels supported and is no longer isolated and alone. And more importantly, she now has a clinic date. And a parent experience. They took the time to listen to me and seemed genuinely caring and interested in my son. The clinic made me feel that my son is important and worth investing time and resources into. It was a relief and reassuring to know that there are people out there keeping an eye on my son and continually adding to their knowledge of the condition. Thank you.
Hi, well, my name's Kerry and I'm also the mother of a child with Alström syndrome, and after the break I'm going to be giving you a personal account of our life with Alström and how the condition affects my son personally. But at the minute I'm going to talk from a charity point of view, and I'm currently the Acting Chief Executive Officer of Alström Syndrome UK, which is a new post for me. So this is how our charity is structured. We're governed by a board of trustees who delegate the daily responsibility of running the charity to me, but the responsibility of managing our big contracts and our research grants to Kay Parkinson, who is the founder and director of Alström Syndrome UK, and to Phil Thiessen, who's our financial director. We then have 4 members of staff. John Parkinson is our family liaison officer, who now mainly works with our adults. Julia Scott is our professional fundraiser and has brought in a phenomenal amount of money into our charity. And so we're extremely grateful to Julia. Iram Shah is our project assistant who works on our Asian mentoring scheme, and again I'll tell you a bit more about that later. And Catherine Lewis, who is our PA and events coordinator. So what is Alström syndrome? It's an extremely rare and complex condition. As Phil said earlier, retinal degeneration. A lot of our children are diagnosed within the first year of life with cone dystrophy, and they have nystagmus and photophobia. Nystagmus is a wobbling of the eye. Photophobia is sensitivity to light. They're also diagnosed with hearing loss, and obesity is common for the majority of our children and young people. And they're also insulin resistant. Cardiomyopathy, dilated cardiomyopathy, can affect children from as early as 3 weeks old and will often go into heart failure. Now, cardiomyopathy, we think, currently affects about 60% of patients with Alström. Not only babies, some babies cannot have cardiomyopathy, but can develop cardiomyopathy during adolescence or later on in life. And if cardiomyopathy appears early on in life, there is a chance that the heart can recover and appear normal, but it will always continue to be at risk and can fail again later on. They have type 2 diabetes. The majority of our patients, so diet and exercise is vital with this condition to try and hold off diabetes for as long as possible. And they can have problems with their liver and their kidneys. And as Phil was saying earlier, we are noticing now that fibrosis is very common in Alström patients, and the majority of organs in the body is affected by fibrosis. So the charity Alström Syndrome UK was founded in 1998 by 2 parents in Devon, John and Kay Parkinson. They had 2 children with a condition they didn't have a name for. They were given lots of different diagnoses before they got to Alström syndrome. And finally, when they did get their diagnosis, I think their children were 16 and 18, and by that time they had lots of complications that if the condition had been caught much sooner, I'm sure some of those things could have been prevented or at least treated early on. So unfortunately they had to learn the hard way, really. So the specialists from Torbay Hospital began getting interested in the condition because they felt that they didn't really understand it and they didn't really know how to treat it. So as Kay and John developed this charity, they found patients from other places in the country and got together a support group and actually arranged a conference in a hotel somewhere down in Devon. And the doctors went along and did their own clinics, really, and their own bits of research, and did see these families to try and get a better knowledge of the condition. Birmingham Children's Hospital became involved from a paediatric point of view. And we then applied to the National Specialised Commissioning Group for multidisciplinary clinics. Now, we got the funding to fund the clinics, but what they didn't want to do was fund us as a patient organisation to provide support to families. And anybody that knows Kay knows that Kay won't stand for that. So she fought and used a document called the Compact, and we are now funded as equal partners in the Alström service. So how rare is Alström? We know of around 60 known cases in the UK, so our children are 1 in a million. We have had an increasing number of Asian families, and I started to work with Asian families back in 2008. Now, prior to 2008, we had 3 Asian children. This is just Asian children on this chart. We had 3 Asian children diagnosed with the condition. Today, that number's actually gone up now as well, but I think we've got 26 families now. And that's by developing the Asian mentoring scheme and working specifically within Asian communities and working with families. And we've actually linked one Asian family we've got a member in Bradford, Lancashire and Peterborough, all the members of the same one family, but by actually working with that family we found those patients and got them referred into Birmingham, and now they're receiving the care that they need. So our clinics, our clinics are only in Birmingham because we have a very limited number of patients. We just work with Birmingham Children's Hospital and Queen Elizabeth Hospital. Now, our children come to clinic and the clinic lasts 3 days. So they'll come on a Sunday and they'll leave on a Tuesday. We have 4 clinics a year in Birmingham Children's, and we'll have 1 outreach clinic in Leeds. When we found some families in Leeds, they didn't want to travel to Birmingham, so the Birmingham team actually went out to Leeds to run these clinics. So when they come to clinic, they'll be seen by a number of different specialists: endocrinologist, clinic coordinator, diabetes nurse specialist, a cardiologist, dietitian, transition coordinator, physiotherapist, ophthalmologist, audiologist, psychologist, a respiratory specialist, and research nurses. So as you can see, for young people, that is a very complex 3 days, tiring, exhausting. But the majority of our families and our children do see the benefit in that. And some of our children actually do enjoy coming to clinic because they see other children with the same condition. They're not seen as different. They're part of a group, and they've made some really good friends. Now, the tests that they'll have in that day, they have the height, weight, BMI, a 24-hour blood pressure monitor fitted, early morning urine tests, bloods, mixed meal tests, echo, ECG, chest x-ray, eye tests, hearing tests. So again, a lot there. But what I like about these clinics as a mother is that you're seeing everybody under one roof and everybody talks to one another, and that's the one thing that you cannot get locally. All specialists are very good in their own individual areas and specialities, but they're not talking to other doctors as well that's involved in your care, and that's I feel reassured by attending these clinics. ACE UK applied for a research grant from the big lottery, and we're just coming to the end of that now. And this has been a fantastic project in that it's developed a database of Ulstrom patients in the UK. And we're working with Birmingham Children's Hospital, Torbay Hospital and Cambridge University. But from July onwards, we will be working with Queen Elizabeth Hospital in Birmingham to keep that going. We've taken skin samples from our children and young people and adults and sent those to Cambridge, and they're growing cells. They've developed fat cells and liver cells, and the hope now is that we can move on to develop heart cells. So hopefully that will aid our understanding of the condition and hopefully support with any new treatments that are coming along. Now that feeds into our clinics, because on the Tuesday of our clinics, when we talked about mixed meal tests, that's all part of the research. Now, not all families take part in research, but for those that want to and are willing to do that, they've got the opportunity for that. And I think that really has supported our understanding of this condition. And it's a platform then to move on to find new partners in research and to try and get an understanding of this very rare and complex condition. Thank you.